It's nice to hear the buzz in the room. Everybody's getting to know each other, and people in the Right Care Initiative have made some wonderful friendships. Let's see, what was that about? The minute Carla walks out of the room, the tech goes nuts. But so, for those of you who don't know me, I'm Hattie Hamley, and I'm standing clear of the microphones because they are turned up quite a bit today. And can you all hear me well?
Yeah.
Yes. So, normally we wait for Dr. Arevalo to get started as our co-chair. But because he isn't with us yet, I just want to get started with a few logistical things, if I may. In our packets today, we have, of course, the agenda is the first page. The second page, Dr. Susan Ivey will be running over with us in a little bit, and that may be something that will turn into a pocket card that your different organizations can use to move your numbers up for blood pressure control and lifestyle information on the back. We also have the biographies of our speakers today, and many of you have seen these materials before, but we have some new people in the room, so I'll just mention that the Right Care Initiative project brief is the next page, and the project brief lists our key partners, and I want to especially thank our funders today who are with us. Sierra Health Foundation, thank you so very much for hosting us month after month since July of 2012. It's hard to believe we've been coming together for that long, but it's been nice to see the progress that we're making together. Also, Novo Nordisk, Genentech, and Boehringer Ingelheim. Thank you for your ongoing support of the Right Care Initiative. On the back of our project brief, you will see this triangle that is also on that poster. And I just want to remind you that what we do every month is we rotate around the key elements of the promising best practices. So, as you can see at the apex of the triangle is patient activation, and we will hear a patient story today that will help us with understanding why it's so important to have that activated patient. We'll also have our program centered around the power of the clinical pharmacist on the care team. So what we do is we cycle through the various components on the Right Care Triangle, which is a synthesis of our promising best practices. The next page in your packet is detail on the higher incidence of heart attack, stroke, and diabetic complications in the Sacramento area, and gives you quite a bit of information about the fact that we have more heart attacks and strokes here and at younger ages, and more discharges to, as Dr. Ertl would say, a celestial discharge, or discharge to morgue, to put it more plainly. So that's why we're here today, because there's a lot we know how to do to turn that around. And if there's one thing that Right Care stands for, it's innovation and not accepting the status quo. And I see the faces of our Right Care enthusiasts in the room over the years, and I really appreciate your coming back month after month to strategize. Dr. Hufford, I have to call you out as our early co-chair, and thank you for continuing to help us lead this program. The next page is the gold bar charts page. I want to especially point out to you that it shows you by medical group in Sacramento what the performance rates are that are reported to the Integrated Healthcare Association through the Pay for Performance program and posted on the state website called the Office of Patient Advocate. And that shows you these very vulnerable patients that I call the patients in the white space. These are the patients that we know are walking unnecessarily toward a clinical cliff of devastating health events. So I appreciate your being here today to help figure out how to stop them from going over the edge of that cliff. Next in your packets is a 2-page project brief on the power of the pharmacist on the care team. This is a very jam-packed synthesis of the data available. I know that Marilyn is going to be doing a lot more, but this will give you the thumbnail sketch of, for instance, if you add a pharmacist to the care team, according to Health Partners Minnesota, in their latest Big Splash study, 71% of patients will be in good control as opposed to 52% for usual care. There are a lot of other great stats in there for you. And then the last thing you have in your packet, importantly, is the evaluation form. We want to hear from you about future speakers, what you want to learn about. And we really need you doctors and nurses and pharmacists to fill out the continuing education form. So if you can't find the time to do it yourself, we're going to ask Right Care staff to help you fill out that information, because if you don't start requesting your free continuing education credits, it's a huge investment to put together the continuing education, and we won't have that contributed by the Health Services Advisory Group anymore if people don't use them. So please, please, please sign up for your continuing education. And if you have any questions about that, please ask our coordinator, Carly. Carly, would you stand up, please? And thank you for all of your work putting this together. So we typically do have Dr. Revelo with us when we start, but since he is still not here and it's a few minutes past the hour, I would just like Dr. Ertl, our co-chair, to kick it off with his introduction of our...
Do we want to go around the room first?
Yes.
So do you want me to just introduce myself and then go that way?
Sure, that's great. And Carla, you can handle, Carla and Chad will handle the microphones. We'd love it if you would just very briefly say your name, your title, and your organization and pass it on, because there are a lot of us here today, 61 people. And then we're going to move on to our wonderful panel of speakers.
All right. Alan Ertl, CMO, Mercy Medical Group here in Sacramento.
Mary Ferguson, Chief Medical Officer, Health Services Advisory Group.
Marilyn Stebbins, pharmacist, UCSF School of Pharmacy.
Nancy England, pharmacist, Lucia, California.
Evans, pharmacy coordinators.
Louder, please.
Leslie Pratt, Center Medical Foundation Director of Clinical Operations.
Teresa Wilson, Director of Clinical Operations as well for Center.
Michael McQueen, California Department of Healthcare Services, pharmacist and pharmaceutical consultant.
Sloan Irving, Senior Clinical Program Manager for ACO of Blue Shield, California.
Hi, Jody DiBartoli, I'm with Blue Shield California, I'm your coordinator. And Linda Pan, pharmacist care coordinator, UC Davis Medical Center.
Lisa Albers, medical consultant, Department of Healthcare Services and Managed Care.
Hello, Maureen Farrelly, Department of Healthcare Services and Managed Care Nurse Consultant. Kristen Robinson, Chief of Chronic and Disease Management for Kaiser.
Roy Schultz-Seingold, Chief Medical and Strategy Officer for Pelican Health Centers.
Jim Corcus, I'm the Northern California Medical Director for United Healthcare.
Sarah Brass, Special Assistant to Chief of Staff, VA Northern California Healthcare System.
Jerry Jeffy, California Chronic Care Coalition.
Good morning, I'm Martha Doherty, HealthNet Health Education statewide. I'm Cardiovascular Health Education Initiative.
Hello,
I'm Laura Polonsky, Clinical Pharmacy Coordinator for Center Health, Clinical Programs and Formulary Management.
Deanne Blankenship, Director of Program Services, California Health Collaborative.
Joan Werblin, Vice Chair, California Health Collaborative.
Mick Smith, with the American Heart American Stroke Association, Regional Director for Get With The Guidelines programs.
I'm Sue Quintus with the University of San Francisco.
Bill Burnett, California Chronic Care Coalition and California Hepatitis C Task Force.
California Hepatitis C Task Force and Nevada County MC Support Group.
Kathy, your name?
Fry, LWF Home Care.
Don Hubbard, CMO, Western Health Advantage.
David Matsumura, Diabetes Awareness and Prevention, County Executive with Nova Nordisk.
Ralph Goldinger, President, Sutter, the head of physicians.
Jessica Nunez de Ibarra, California Department of Public Health, Director of Coordination for the California Wellness Plan implementation.
Stan Learn, Clinical Division Lead, Albertson Safeway.
Risa Vatanka, Pharmacy Strategic Alliances Manager at Safeway and a faculty at UCSF.
Dennis Ishisaka, Pharmacist, Blue Shield of California.
Susan Ivey, physician and professor at the School of Public Health, UC Berkeley.
Liz Helms, President and CEO, California Chronic Care Coalition.
Eddie Tomajima, University of San Francisco. Sandra Perez from the California State Senate, Office of Research. Jacqueline Weiss, Regional General Manager at Genentech.
Eva Kroppel, Director of Advanced Pharmacy Practice at California State University.
Elaine Lynn, Local Coordinator for the Surgery Future Medication Adherence Awareness Campaign.
Steve White, Health System Business Manager with Novo Nordisk.
Forrest Carter, Coordination Executive, Sutter Health. Dan Tuberty, Account Manager with Behringer Walnut.
Emerald Montgomery, UC Davis, Research Analyst.
Don Forrester, Medical Director, Meals for Health for City International.
Michelle Ballou, Project Manager in Clinical Innovations for Health Physicians.
Doug Robertson, Regional Director for Health Physicians here in the Sacramento area.
Rachel Abbott, Research Analyst, California Department of Healthcare Services.
Jim Ellsworth, Capital Health Network.
Kylie Haynes, Senior Program Officer here at the Sierra Health Foundation. Welcome to the foundation.
Olivia Casari, Public Health Officer.
Great, well, thank you. And I don't know why I'm getting feedback, but I'm Jose Alberto Arevalo, the Senior Medical Director for Sutter Independent Physicians, and I'm also one of the co-directors along with Alan Bertle on the clinical side for Right Care. And we're really happy to see such a packed house today. It's hard to find parking, and I apologize to all of you who had some difficulty at the park on the highway. So just be careful when you cross the highway. But I wanted to give you a brief update, and I'll turn it over to these wonderful young ladies that I work with. One of the things that we are very excited about is that we know that there are some clinical guidelines in some of the health systems around hypertension management, but we also know that sometimes there's a gap for those clinical guidelines that might not necessarily go out to other physicians who may not have the benefit of being in an integrated system or involved directly in an integrated system. So one of the things that's exciting for us is that we're putting a product together that I think many of you know about, which is our first Right Care product, and that's hypertension guidelines for our capital region based on JNC8. And we know there's some controversy, but we believe that we need to stand behind a set of guidelines that is going to help guide some of the clinicians that I talked about. So I've been working with Susan Ivey, who you've all met, who is from the School of Public Health and who's done an amazing job, as well as Mary Ferguson, who's the CMO for Health Services Advisory Group. And we believe that this is going to be a product that will be very useful because it's unlike the 60 pages you sometimes get of clinical guidelines or even the 5 pages, that we're going to try to summarize this, and Susan and Mary will tell you a little bit more, in a handy-dandy little pocket card that will give clinicians some real good direction as to what to do to improve care for their hypertension patients. So I'm going to turn it over, and thank you again for being here.
Thanks, Jose. So one of the things I liked about him standing here with me and Mary on the two sides is that, there's been a lot of back and forth, trying to come up with something, people are comfortable with. You guys have weighed in too. Did it turn off? And so the other thing that this activity kind of refreshed in my brain is that in medicine, there's never a there that's finished. There's never something that's going to be static. It's always going to keep changing. And I think most of us who practice medicine, you just get used to that. Like, yeah, those were the old guidelines, but these are the new guidelines. So these are the JNC 8 guidelines that we put into a little algorithm. Let me see if we can click to that. And we made a little bit, but not much modification based on some of your feedback. We did put an asterisk next to the 60-year-olds, and down at the bottom there's a bolded part where it says, while the 8th Joint National Committee currently uses a goal of 150/90 for adults age 60 and older, this recommendation is undergoing discussion and refinement by multiple national organizations based on evolving evidence. So I had presented the INVEST study the last time when I was here, and the evidence that it showed, and then Mary was saying this morning, oh, and there's another new study I just read, I have it in my briefcase. So, the life of change in medicine is constantly toting around some articles and stuff. So we know this won't be written in stone or anything, but I think we've framed it so that it can be folded in half into a little card, and then Mary said this morning she can take it the next step of making it a little smaller. So the back side will be the rounds of going back and forth with goal blood pressure and those patients that aren't able to reach their blood pressure goal on one medication or with medication and lifestyle adherence. And that also has some new references down at the bottom. And then the next page will have those lifestyle change information, which I think physicians are actually particularly bad at most of the time. So it's really nice to have a little refresher card where you can say, okay, what is the DASH diet? What's the difference between the DASH diet and DASH sodium? If my patient's on the DASH diet, how many millimeters of mercury drop can I expect from that? If they do physical activity, if they lower their sodium intake, if they do tobacco cessation, what's the blood pressure payoff? So I really like this one based on one of the American Heart Association's tables. And we've added tobacco cessation and the motivational interviewing. And the motivational interviewing article I read and is cited here showed that clinicians using motivational interviewing for tobacco cessation accomplished 4 times the amount of tobacco cessation for their patients compared with usual care, which usually consists, at my office anyway, of giving somebody a phone number to call for that phone tobacco cessation program. You guys may have a more rich environment, but it's really, the evidence is there for motivational interviewing. So, Mary.
Okay, so with this, we're about ready to roll it out, and we would welcome suggestions from you all as to how you think it can be rolled out. We are currently thinking of putting this in electronic format as well as in a pocket-sized hard copy, especially the treatment algorithm into a pocket-sized hard copy for clinicians. So, but any other thoughts or ideas, suggestions, we're welcome. Just please send it to us, to Dr. Ivy, to Dr. Arevalo, and to Hattie. We will welcome that. The second thing I wanted to let you know, an exciting thing that's happening is that, if you recall, in December, Dr. Earl developed a hypertension survey for his physicians, and he implemented it and got some remarkable results. And so that hypertension survey was graciously shared by Dr. Earl to anybody who wants to use it. And now CAPG, the California Association of Physician Group, would like to implement it more broadly across all the physician groups that are their members. And USC School of Pharmacy, if you all know Steve Chen, has graciously agreed to also support it by implementing the actual implementation, supporting the actual implementation of the survey tool itself. So that's an exciting development in terms of hypertension, so that we can have an aggregate knowledge of what the physician's knowledge base is and what their barriers are currently in treating hypertension. And if you, any one of you would like to use that survey tool, please let us know too, and we'll work with you. Thank you.
Thank you.
Before we move on, we want to make sure if there are any questions about this, we'd like to be able to answer them now. Any questions about this particular endeavor? Because it is, again, it's guidelines, it's a roadmap, it's a way to assist clinicians to go from point A to point B to improve care for hypertension. And we know that, you know, there are guidelines within certain systems, and this is not intended to surpass or to replace those guidelines in the system. It's just meant to be another tool that can be used, particularly when there are clinicians out there, and there are a lot of clinicians out there who don't have the sort of benefit of being under an umbrella organization that has helped them around these kinds of things. So we're really excited about this. So if there are no other questions, yes?
Oh, just one idea. Mary put a bug in my ear. She said, you know, we're thinking about developing a survey for the medical assistants on when they know actually how to take an accurate blood pressure. And I think that that's the greatest next idea since sliced bread. And so I will go think with that technical term this afternoon to see if I can come up with something that might assess the MA's knowledge base. Because again, if you remember the results of the survey that I did with our docs, they felt in general that the MAs did a very good job at assessing blood pressure. My guess is that that's wrong. My guess, and so how do I go back to them and say, actually, everybody needs to be retrained to a higher level, higher standard of knowledge about doing it correctly. Sitting on the floor, feet on the ground, arms supported, nobody talks. All of those things that you have to do to get an accurate blood pressure. So, thank you.
Thank you for getting us started.
I just wanted to say, would you please put in there something about calibration, because most of these are not done manually. And I wonder in some of the clinicians' offices if they're really calibrating their monitoring.
My guess is heck. But that's a really good point. So email me your ideas on this stuff.
Also, I would suggest having advice for the patients if they're asked to have their own a machine at home, because there's a proper way to take it, and also which kind to use, because there's wrist, arm, and so on, and you know, certain ones you shouldn't use, certain ones you should. That probably should be added too.
Yeah, it's a great idea. Okay.
Yeah, you might want to ask them to bring it in periodically so you can look at it, and because I know that's happened. That's happened. We found that some of them at home are not really well calibrated. So great suggestions. We also, any other suggestions you might have, we'd love to hear from them, and we can let any one of us know. But what we'd like to do is move on with the agenda today, and I'd like to, and she again doesn't need any introduction. Liz Helms has been with us since the very beginning of Right Care, now over 2 years ago here in the Sacramento region. And Liz is really one of the public health advocates for chronic care in California that's been well recognized. She currently is the chair of the California Chronic Care Coalition, and it's an alliance of nonprofit social consumer and provider organizations united to improve the health of Californians with chronic conditions or diseases. And she was instrumental in getting the San Diego Right Care Initiative off the ground. And she was one of the coordinator for the San Diego Right Care Initiative. So Liz is going to talk to us about some of the work she's doing. So.
Actually, today I've asked her to be here in the form of telling her patient story. And she's got a really important story to tell. Thank you, Liz, for being here.
Thank you so much. Good afternoon, everyone. So you see me here all the time with my cap on for the California Chronic Care Coalition. And there's lots of reasons why we as patient organizations wear these caps. A lot comes from passion and personal experiences. I've had enough personal experiences in my lifetime to finish my old age without anything else happening, but it doesn't always work that way. So I'm going to go through a little bit of an experience that I had and why I'm so extremely passionate about implementing clinical pharmacy, MTM and CMM into not just the state of California, but all over the country. So I'm going to go through something that happened to me. Back in the 1980s, I started taking a beta blocker. Wasn't necessarily for a cardiac issue, but they found that there was a neurological component. And then in 2008, I began taking an inhaler because I was diagnosed with adult asthma. And that runs in my family. And so I was really lucky not to have it till I was into my older years when my brother had it when he was very, very young. And then I had an asthma flare-up in May of 2011. And I had to start taking a lot of extra rescue inhalers, which was albuterol. So now I'm taking inhalers, I'm taking my rescue inhaler, and from May of 2011 through January of 2012, I ended up in the hospital 3 times. I had 2 admits. I had an ocular hole, lost my vision in my left eye. I had 3 CT scans, and I was on stroke watch when I was admitted. Never stopped working through it, just took some time off to get some rest in the hospital. In April now, so we're talking May of 2011, now we're into April of 2012, I'm refilling my beta blocker. Pharmacist says to me, have you been having any problems? And all of a sudden the light bulbs went on and I went, oh my God, this all makes sense to me now. So my medicines, as probably many of you know, were contraindicated. And I also found out later that they were level 1 warnings, should have been caught. They were the highest level of warning that there is. So I was taking a beta antagonist. Well, now I realize all this is happening, so I request a medication therapy management appointment so I can go sit down with my pharmacist, go over all my meds, have a discussion, have them look at everything, and I was told that they didn't do it. And I said, why don't you do it? Well, we're not reimbursed for it. You have to go talk to your doctor. So I go back to my doctor, have a discussion, and he just thought that, that I was on the right amounts and I shouldn't have had this problem, but I had the problem. So, what do you think all that cost? I mean, these are all preventable hospital stays, but 3 times in the hospital. What do you think that cost? And this is one of the reasons why I'm so passionate about the work we're doing, why I'm so happy that Right Care put the clinical pharmacist on the care team, and why now the Department of Public Health is so interested in implementing, and we're all kind of coming together, and the agencies are all talking with each other. So it's very, very exciting. But my story, as you know, is not alone. Adverse drug effects are a serious public health problem. And I just wanted to bring up a few key facts that I pulled down from the CDC. 82% of American adults take at least 1 medication and 29% take over 5. My mother took over 15 and I used to put her box together every week. 15 a day. 700,000 emergency department visits and 120,000 hospitalizations are due to adverse drug effects. $3.5 billion is spent in extra medical costs because of adverse drug effects. And at least 40% of the cost of ambulatory care are estimated to be preventable. Don't you all think it's time to implement the care team the way it's supposed to be, reduce costs, improve quality, and get the care we need into the system? Thank you.
So, yeah, remember, part of our charter is do no harm. We do harm with adverse drug events. And so I'm a minimalist as far as medications go. And I got that from my mother. She's 88 now, and she's on no meds, and she's the only one in her bridge clubs. And all her other neighborhood societies that actually is on no meds, and they can't believe it. So I don't know if the rest of you are enjoying the effects of the rain that came in last week, because my allergies are killing me. So this is our pharmacist in the house. So it's my pleasure to introduce Marilyn Stebbins. We met when I arrived in Sacramento just over 2 years ago. She's now a professor of pharmacy She graduated with a BA in biochemistry and cell biology from UC San Diego, and then got her PharmD from University of California, San Francisco. She had started her academic appointment there in 1998, and then returned in 2013 after she left us as the Vice Chair of Clinical Innovation. She has a lot of clinical expertise, ambulatory care, geriatrics, managed care, Part D Medicare in particular, and providing services to the underserved. She has also done a lot of teaching as it relates to Medicare Part D, innovative practice models where she's been jousting for a long period of time. There's rumor, because of that jousting, that she's a founding member of the Northern California chapter of the Society for Creative Anachronism. But I think that that's just rumor. She also has done a lot of teaching in health policy, managed care leadership, and she's going to talk about innovative practice models today and return on investment for those, including the pharmacists. So join me in welcoming Marilyn Stebbins.
Well, before I get started, I've wanted to do this for a really long time, but I'd really like Hattie and Liz to just come up here for 1 minute. Just 1 minute. And I just wanted to, if you hurry up, there's not. And I want you both to come up here because as a member of the Executive Admissions Committee at the UC San Francisco School of Pharmacy, and as faculty, and we're nearing our graduation time, I would like to confer honorary pharmacy degrees on Liz and Hattie because the two of them are the largest champions of pharmacists on the care team that I've seen in the lay public. And I can't tell you how much that means to me as a pharmacy innovator and educator to have people in your positions advocating for pharmacists. So you have your honorary PharmDs.
At Harvard was in knowing what facts are and using them for good public policy purposes. And the facts for pharmacy are rock solid. Marilyn is going to go over some of them. And I, like Liz, am a grateful patient to a pharmacist who said, I wouldn't take that medication. And I said, but I said that to my doctor, and he said I really should. And he said, well, I think you need to call him back. And because it was night and it was weekend, I ended up calling my cousin, who's my first cousin, who's a physician, and I said, here's what I know. And he said, I agree with pharmacists. Don't take that. So I am very grateful to what you do, and I think that if there's anything that Right Care stands for, it's taking the facts and applying them to the situation. And the facts here are that by adding a pharmacist to the care team, patients have better outcomes. The facts are also that our delivery system is not evolving as quickly as it needs to for the patient benefit. So I look to all of you in the room to figure out how do we take the knowledge and apply it to improve patient outcomes. So thank you, Jessica, for the Department of Public Health is taking up the cause, and perhaps we'll hear about that a little bit later during our discussion session. Great, thank you, Marilyn.
You're welcome. So today, what I really want to talk about is, I'm only going to do this first bullet, I think, because I'm going to talk about the evidence of the pharmacists on the care team, and in particular in hypertension management. I'm also going to talk a little bit about an innovative practice model